In the head and neck sphere, one abstract I found particularly interesting was in the adjuvant context, so post-operatively, looking at different chemotherapy regimens to be used concurrent with adjuvant radiotherapy. In clinical data, the standard regimen is cisplatin 100 milligrams per meter squared every 3 weeks. It's a challenging regimen for both doctor and patient, very toxic. And in clinical practice, doctors have largely moved to alternative regimens. Amongst those alternative regimens is weekly cisplatin at a dose of 40 milligrams per meter squared. And there was data at ASCO to show that that is not an inferior regimen to use. And that's I think, pretty impactful on practice, because we'd all love to be using purely weekly. And I think that this gives justification to do so. I also found interesting an abstract coming out of India looking at low-dose oral metronomic methotrexate. A brief history lesson is in order to put this into context. As our field moved from methotrexate to single-agent platinum or 5-FU to platinum 5-FU doublets, it's an interesting history, because at the time this happened, response rate was the king of the hill measure. And as you move to more toxic, more aggressive measures, you got a higher response rate, right? As you moved from methotrexate to carbo to cis 5-FU, you got more high response rate, you got more toxicity, but through a modern lens, you did not get improved survival. And while there were no robust quality of life measures done in any of those historic studies, it's not hard to say, anyone who's seen the side effects of cisplatin 5-FU, that you're not improving quality of life with that. It's an interesting way that we got to where we are. And this was a little bit of back to the future of looking at how effective in a resource poor setting where there's limited access to these agents, how well can we do with low dose oral methotrexate, right? A very patient-friendly, inexpensive, other than some mucositis, relatively non-toxic regimen. And it did impressively well. So am I going to stop using my current go-to regimens, which are pembrolizumab for my PD-L1 high patients of CPS high, or in my practice, the Tahara regimen of carbotaxol cetuximab for those who are under that? No, I'm not going to do that. But after that, as a later line option in a resource wealthy country, yes, I would consider going back to that as a later line option. And in particular, in the era of COVID-19, where there's a risk to healthcare environment exposure, an oral regimen becomes particularly attractive at this moment in time.